So fertility care is a evolving process all the time, and it's offering assisted reproductive technologies to millions globally. Also, LGBTQ plus patients are fast growing users of this technology. There are a lot of barriers that persist in spite of the national guidelines that are available. All the gender identity patients are now seeking options like IVF, IUI, even gamete donation and surrogacy. But they are facing systemic inequalities, discrimination, and heteronormative practices. So before we proceed ahead, I would also like to tell you what cultural competence means. It means that providers are aware of their biases and understand diverse backgrounds and engage effectively. Through this review, we will aim to characterize the barriers that are faced by LGBTQ plus group and fertility care. We would see both the perspectives of the patients as well as the healthcare providers. This study design involved in this research paper is a systematic review, and the PRISMA guidelines were followed. PRISMA means preferred reporting items for systematic reviews and meta-analysis. It's a flowchart based guideline wherein we put our data in the flowchart so that all the details are covered. Also, during this review, there were 6 databases that were used to gather all the research papers and conduct a review, namely Medline Ovid, Embase, Sinahel, Cochrane Library, Clinical Trials Gov, and PsycInfo. Even Scopus citation search was used. The eligibility criteria included LGBTQ plus patients and their partners who were seeking fertility care and the fertility providers. Any study on cultural competence was included in this study. This design is an original peer review and observational study. Also, there is no comparator group that was used, and any outcome reported in the literature, whether it was qualitative or quantitative, were included. For data and quality, data extraction was done and duplicates were removed. The review quality was enhanced by using a risk bias instrument, which is used for cross-sectional surveys and interviews. Joanna Briggs checklist, which is a qualitative checklist which helps in organizing the research, and descriptive synthesis was used. No meta-analysis was performed. Also, due to qualitative diversity, the results were summarized narratively rather than quantitatively. The results, they scanned around 1,747 records, out of which only 25 studies were included. I'm so sorry. Yeah. So this is the PRISMA flowchart through which they have summarized how they conducted their systematic review. They analyzed more than 1,700 papers, duplicates were removed, and then other papers were excluded wherein the paper quantity was like not available, only the title and abstract was available. They could only assess and the full papers that were available. Also, they excluded anything that was published in conferences or as a poster, or that was not an original article or not related to their topic, or if there are no outcomes reported, all these papers were excluded. Hand citation was used, and finally they could come up to 25 studies that was included. One more thing I would like to add, out of these 25 papers, 21 papers were based on what patients' perspectives were, whereas the rest 4 papers described what the providers wanted to convey, the healthcare providers. The study characteristics include there were 15 interviews, 4 surveys, 1 focus group discussion, and 5 studies were mixed in nature. Geographies that were covered were North America majorly, Europe, Oceania, and even singular papers of Asia was covered. Population under consideration was same-sex couples, 13 papers, transgenders, on non-conforming genders, 6 papers, and LGBTQ plus minority groups, that were 2 papers. But there were no papers on two spirits or indigenous LGBTQ groups were found. Now we will discuss what the paper could find, what the barriers that were addressed during the paper. So first barrier that was addressed was heteronormativity or cisnormativity. They could conclude that there were lack of signages or case taking forms or language that were congruent with the preferred pronouns. Also, there were certain lesbians that were labeled infertile, and the information for the group was not available in a tailored format. Next barrier was discrimination and gatekeeping. So the most heart-wrenching barrier that was found, that there was discrepancy in the fees who was like for the people who were of same-sex couples. They were being charged higher fees. Also, they had to undergo mandatory social work visits, NGO visits, and there were, in spite of available guidelines and in North America, because this paper is West based, there were still knowledge gaps. Other barrier that was faced or noted during this research was trans and non-binary specific. There were triggering outcomes for the treatment. For example, there was a paper wherein they mentioned there was breast growth that was triggering for the patient with the identity group. Also, so they used to stop the hormone treatment, or they used to miss the exams, or there were not an enough care for pregnancy available. They were either labeled in a wrong gender as well. Also, apart from all these triggering factors, the psychological support that was available to them was not good. Now, a few providers' perspective are also provided. So what healthcare professionals face as a barrier is heteronormativity and lack of resources. There are limited resources for recording the cases. Also, the healthcare providers used to fear that you should not use a wrong language or a wrong pronoun. And there is no long-term data available. Even our literature is not, properly labeled. The interns are also very fearful in attending to such cases due to lack of experience. So now we come to the solutions that were discussed. So patients were looking out for systems that were reflecting not just their identities, not just tolerance, but true inclusion. So the suggestions that were sent by them were the resources should be tailored to their needs, the form should be inclusive, the pronouns preferred by them should be used, and also there should be groups that should be available. System level solutions were gender neutral bathrooms in the healthcare facilities. Pride flags and inclusive signages should have been used. Non-discriminative policies should be created, and the healthcare providers should be trained. Solutions specifically for providers that were suggested were there should be specific written policies. There should be collaboration at community level. Decision aids and patient testimonials should also be there. And there should be a proper care guidelines for them. You know what happened in this research paper was the patient had to be the source of information rather than the healthcare professional being the source of information for them. The relationship got vice versa. This is the level we have to achieve. So much training is required right now. This paper could record the barriers in a well-documented format. The solutions offered were feasible, and more research is needed on such healthcare practices so that a good level of care is provided to all the group in need. The strength of this paper were they had an elaborate database search. The quality control in the paper was high, and it included reviews from both the patient and the providers. The limitation with this paper was the meta-analysis wasn't possible. There were less to no studies on LGBTQ plus people of color, because there are certain groups of color who were facing racism issues. So there was no such proper documented research paper on that aspect as well. Also, two-spirit data wasn't available. So by concluding this, I would like to emphasize on the fact that cultural competence is crucial for equitable fertility care. The persistent barriers are there, but we always have a solution, and this paper enlists them very well. And institutional and research guidelines and paper should be done, because this will lead to cultural competence or cultural humanity. That is also a term that is now used for cultural competence, and it will provide us an opportunity for lifelong learning and open listening, and we will be able to achieve better healthcare goals. Future directions that can be picked up from these studies are: the studies can be interventional in nature, intersectional focus, or multiple sections can be focused at that time, and the education level should reformation should be there. Okay, so please let me know if I could solve any doubts so that we can start with some discussion points based on this paper.
In case anyone has questions for the presenter, I think they can ask now.
Okay, so we'll move on with insights from Dr. Aqsa.
Yes. Deepika, do you want to discuss these points now or the ones that are on the screen currently?
Let's have some points from doctor, and then we can continue with the discussion.
Sure, no issues. So, first of all, thank you, SIMSOG, for taking up this important aspect of fertility care, and especially in obstetrics and gynecology. And I believe you mentioned that this is the second in a series. So, could you also tell me what was the first one, the research team? Was there a topic on LGBTQ in
Nandit,
ObGyn before this?
the first topic we discussed in the series was OBGY role as a in the times of crisis.
Okay, okay. Yeah, right. So, first of all, congratulations, Deepika, for selecting this, I think, very important, very challenging also, but something, which is now, we can't say that I'm not going to say an exotic topic because this is the reality of our times. And you've chosen a very nice paper. So I agree with the strengths that you mentioned, that, the work done by the researchers, and this is from the University of Toronto. So they've done a good work in terms of doing this systematic review and giving out the findings. Let me first talk about the technical aspects, and then I can more talk about the topic related things. So I think in terms of the selection and the presentation, you have done a good job, and also given a basic understanding to people of what the LGBTQIA means. So that's really helpful. One limitation of the paper that you could have highlighted was, in terms of the lack of the Asian population, which of course you have mentioned that, and they've also mentioned as the limitation that they do not have, especially when it comes to South Asia and trans identities, that's a different world altogether. Whereas the studies that have been selected are mostly catering to North America or European population, where the understanding of gender and sex is completely different to the gender and sex understanding in the South Asian context. Second thing was the study didn't speak anything about the intersex people. And when it comes to intersex people, they represent a substantial proportion of clientele in our infertility clinics that a lot of infertility specialists see. They may not come out as LGBTQIA plus population. They may just present to you as, let's say, a married couple who is facing infertility. But it also comes in LGBTQIA plus, and in India they are included in the Trans Act. But I think in the article nowhere the intersex people were mentioned. So that was something on which maybe some discussion could have been there. And one thing which I think was lacking in terms of the results that the article gave was the intersectionality, which you also mentioned and pointed out that the intersectional, like future direction of studies, we can look at intersectionality because, even when we say same-sex couple, that term which is used in the paper and which was also used in the slide can have a lot of hidden layer because then we are assuming that there are two women and it's a lesbian couple, which is not necessary. The other person may be a trans woman, right, and not a cis woman. She may be an intersex woman. She may be a bisexual woman. So we don't know. So words like same-sex couple reduce the thing to their sexes or reduce to the act rather than their own identities. So language could have been, I would say, more inclusive and better in this paper, which has good language, but I think it still can be better, right? And certain aspects of intersectionality, for example, the elderly LGBTQI plus couple, because age itself can be contributing to a lot of factors. The stigma of infertility itself, like it has been mentioned at one place in the article that the lesbian women were called infertile because they had come to a clinic, but they were not infertile. It's just that she's married to another woman and cannot have children through the usual means of how a cis couple has. So the stigma of being called infertile or the stigma of going to an infertility clinic, I think that could have been better extracted from the 25 studies that were selected. And that could have been highlighted better. Then again, they mentioned the intersectionality that they missed out on race, which of course is important from North American context. But when it comes to our context of Asian and South Asian, the intersectionality would be in terms of religion, because a lot of religions may infertility can be a problem. It can be in terms of caste. It can be in terms of the class, which is because most of the infertility treatment is being paid out of their own pockets. It can be also in terms of family support. Some people who are having family support, some who are not having family support, whether they are out or not to the world. So a lot of factors are there. Uh, Now coming to the aspects in terms of an LGBTQIA, topic and in Indian context, and this is the in general for all the people in the audience that if you are really wanting to do work on this topic, whether it is from exam perspective or later on in your clinical perspective, there is some knowledge that you must have to excel on it. And that is in terms of law. In fact, just last week, I was facilitating a session with the nurses on fertility options for LGBTQIA+. And with a lot of heavy heart, I had to tell them that in India, ART as well as surrogacy is not allowed for transgender people. So the in India, as you know, and in the paper, and nowhere we found it talking about the law. What do is the law thing? Because that's also bad. Of course, it was looking at cultural competence, but law is also important. Is that in India in 21, we had the Surrogacy Regulation Act coming, we had the ART Act coming. We also have other acts which play a role like MTP Act, PCPNDT Act, and of course the Transgender Persons Act. So in the current circumstances, the ART procedures are only allowed for the cis married couple, right? And the surrogacy is also not allowed for trans people. It's only allowed in terms of altruistic surrogacy, and that too for a couple or for single women who are divorced, widowed, like that. Because why I'm saying this, there's a lot of craze, or rather, towards freezing of the gametes or freezing of eggs and sperm nowadays. And a lot of trans people are misinformed about it. They go for freezing of their gametes. And the issue is that even if they're frozen, they can't legally use it. Because since the last 3 years, our guidelines for surrogacy and ART have changed. And that is something which can contribute to the biases of the providers also. Because they're like, if the government only is not allowing trans people to have children, why should we allow them to have children? That there must be some reason why trans people are not allowed to adopt children or why they're not allowed to have children. So that can also contribute to our biases. Rather than saying that, okay, fine, this is not being allowed, but is there a scientific basis for it or is it a bias? So, like, just for the information, we challenged in Supreme Court regarding the Surrogacy Act that it is not allowing trans people, single women, to go for surrogacy. We said there's no biological reason or scientific reason why a single woman should not be allowed surrogacy and why a divorced woman should be allowed surrogacy, right? So we are challenging that, and I think somewhere down the line, as medical professionals, we shouldn't just say, ki, okay, government has banned and therefore the ban is correct, but also challenge that medically and scientifically and look into our own biases. In India, we follow the WPATH guidelines. I think it's important to understand WPATH is the World Professional Association for Transgender Healthcare. And they've given certain guidelines, which also have guidelines on fertility management, or rather fertility preservation, especially when you are looking at transition in trans children at the time of puberty using puberty blockers, etc. So I would suggest that all the students should definitely go and read those guidelines. And we also now have the draft Indian guidelines given by Directorate General of Health Services. So it will be good to focus on that. And then to also nudge our own organizations like Foxy and ask them what are our guidelines, Indian guidelines to be practiced by Indian societies and members of those societies. So in the longer term, we need more of those guidelines also to be available. But yes, overall, I would say that good selection of the article, very articulate presentation that has covered all the aspects, which was also educational to us. But yes, I think we need more Indian context, more legal aspect to be understood for it, and more understanding of intersectionality of the topic. Thank you. I can come back if there are any questions or remarks, or people can ask questions to Dr. Deepika also.
Thank you so much for your valuable feedback, Doctor. In the defense of the papers, I would just like to highlight a few points once again. Yes, the paper was not using all the possible terms that were possible, maybe because there was a lack of research papers available for them to analyze, or and also this being as in mentioned in the paper, as this is an upcoming topic, also the group is in the minority sector, so it has not been explored much, and which should have been done much earlier. Also, another possible reason while I was practicing I could find out was that people are still stigmatized, especially in our country, and this being a new concept, people are still exploring their avenues in current times.
I think that in fact shows that since, from Asia, they could get only one paper out of the 25 papers. That shows that there's a lack of research, published research on this topic. And as I mentioned, in India, the problems are manifold. So therefore, there is actually a need of lot of published research on this. This is for all of you, maybe in future research, you can include working on this.
Definitely.
Okay, so now now we will open for questions. Anyone has any questions, please come forward.
I think Porus has a question. Hi, Porus.
Hi, ma'am. Thank you so much for joining us today for this journal club. It's really great to hear from you, especially when it comes to OBGYN as an aspiring OBGYN. Having said that, I have a question for you. So, like, since we are like community or a society of students who aspire to be OBGYN or have some interest in OBGYN where we would like to contribute to the field. But and uh, intersectionality is important, and hence the topic of LGBTQ plus care in OBGYN is of utmost importance. So, what would you suggest for us as medical students who are aspiring OBGYNs, that is probably not
Mm-hmm.
like not at that level of being a practicing OBGYN.
Mm-hmm.
Like, what would you suggest us that we can do at this stage? And going forward, what are your suggestions for us when we grow up to be practicing OBGYNs or or in general for those who don't think of going into the OBGYN field, but like more so in LGBTQ plus care or women's health or of sorts.
Yeah, I think that's a wonderful question for us, and I believe that in future, these boundaries are going to blur. Because right now the image is that, ObGyn is a gynae means a women's health related branch. But then as these boundaries of gender and sex are going to get blurred more and more, because there will be people who will say we don't have any gender, we are gender non-conforming, or we are bigender, or we are agender, or I'm a trans man and I need gynae services. So somewhere, I think it's not going to be restricted to only gynae ops to cater to a particular group. Of course, that will be there, but then more and more people will be, also accessing services from other specialities. Just to give an example, there are trans men who may have, menstrual disorders, but they are not going to a gynae OPD because they feel it's a women's OPD. And as someone who has left the woman's identity, for them to go to a gynae OPD becomes even more difficult. So they would rather go to a general surgeon and say that I have abdominal pain. Now, it becomes therefore more important, even if you're a general surgeon, to identify that a trans man with a issue related to menstruation may also come to you, right? Or they may go to a derma OPD, or they may go to general physician also. And therefore, I think while we are focusing more on specialities generally, when it comes to LGBTQIA, those boundaries that get very much blurred. Also, there is a general, phobia or that people have when they're going to doctors, hospitals, because they feel I'll have to expose. They'll come to know about my organs, they'll talk about my history, they'll not use my names correctly. And therefore, every opportunity that you have with a trans or LGBT patient may be the first and the last opportunity. And if you don't win their confidence, then their perception that the medical system is transphobic grows further. And therefore, every doctor who meets a trans or queer patient has kind of a responsibility that they should create an environment and an interaction which is so friendly that their trust of doctors grows. And now, when you refer them to go to and see a gynae, they'll be, more comfortable going and doing that. So I think as an MBBS doctor, all doctors have a responsibility that they should be able to cater to a trans patient or a lesbian patient when they come to their clinic and be sensitive towards that. In terms of future, I think the various specialities that we look at, gynae is one specialty that we have found to be a place of challenge when it comes to patients, especially trans men, to navigate that. Because as I mentioned, it's a very binary classification. कि हमारी अंडरस्टैंडिंग है गायनी ओपीडी सिर्फ औरतों की ओपीडी है, जनाना ओपीडी है. And for them, they will not go to an OPD which pushes them back to their own identity. Even cis women sometimes find it very uncomfortable to go to a gynae OPD, right? Because there is some narration कि ओ यहाँ पे violence होता है labor room में, or that it is not respectful, my privacy will not be there, or And especially when they're presenting with STI or when they're presenting with infertility, there is an added layer of stigma which is attached. Some work has been done by Foxy. There are some societies which are also working with trans men, especially to look at menstrual disorders. But I think more work needs to be done. And that work needs to be done with the patients. We need to ask them how do they want to make the services friendly for them. Now, one common concern that people raise, like for example, Deepika also mentioned that in the paper it was written that there should be gender neutral toilets. Now, by gender neutral toilet, what does that mean? Does it mean that men can also enter those toilets? Then the cisgender women are not going to be comfortable, right? So we do not do any intervention that which makes trans people comfortable but makes cis women comfortable, because that resistance will come, which came in US, for example. And you see how in US now we are regressing in terms of transgender reform frame. So we say that it should be that gynae OPD or that labor room should be comfortable to a transgender man also, and it should be comfortable to a cisgender woman also. भाई उसको प्रोनाउन शी पूछना है तो वहां तो आप शी बोलो, जो नहीं कि हर एक को आप जेंडर न्यूट्रली कर दो। भाई आई वांट टू बी कॉल्ड शी, देन यू शुड कॉल मी शी। फिर वहां आपको दे प्रोनाउन नहीं यूज करना चाहिए, वो गलत हो जाएगा। या मुझे सिर्फ विमेन ओनली टॉयलेट चाहिए तो मुझे विमेन ओनली टॉयलेट दे दो, right? I should not be denied that by saying कि all toilets are gender neutral and men, women, anyone can enter. So somewhere that thinking will have to come in the long run. Otherwise, we'll face a lot of resistance from the women's group, who will say that these are men who are encroaching our spaces. So while we create more reforms in gynae obs or infertility management with reference to that, we'll have to be mindful of this resistance that can also come to our place. So yes, I mean, there's some work being done on menstruation. There's some work being done on pregnancy in terms of trans men. But then there's certain areas where not much work has been done. For example, cervical cancer screening in India. If you see cervical cancer screening, we don't think about trans men in that screening procedure. Or when it comes to even breast cancer screening, we have mammography guidelines only for women. We don't have those guidelines for trans men and trans women who may also get breast cancer. Or when it comes to, for example, something as simple as that, and I give this example all the time, is what is the cutoff of hemoglobin for saying that someone has anemia? So we know that WHO says that for men it is 13, women it is 12, pregnant women it is 11. What about a trans woman? What is going to be the cutoff for her? So something as simple as that, we have not sorted that yet out, right? So we need more research that looks into these neglected areas of medical research in the past, because more and more trans people will come to you as doctors now in future. So yes, a lot of work to be done in gynae, obs, and in general in medical care.
Thank you so much, ma'am. Actually, you even answered my follow-up question, which was going to be in terms of what you said. For example, like trans men or gender non-binary people could come to you for, let's say, menstruation disorders, and because the medical terminology since time forever has been very uh, binary, that like ObGyn is for women whatsoever. So like I was going to ask how could we be more approachable in terms of, like, let's say, like telling what services we provide and so on and so forth. But I think I got my answer while you spoke only, that it's best to involve the masses and involve the population and understand their perspective, and it ultimately falls under the whole, like deprofessionalization, decentralization of care, but at the same time uh, inclusivity, I would say. And I think I got my answer from your previous answer as well. Thank you so much again.
Thank you.
If you have any more questions, please go ahead. So, ma'am, there were few questions that came up. Uh, Actually, if the art has grown so much, so but still we see the financial burden is always there on the trans people in terms of art facilities accessing. So, how can we access? How can we address this thing, and why it is there in the first place?
Is that to Deepika or me?
Ma'am, to you.
Acha, acha. Thank you. So, I think that's a very, very valid question. And we say that it is very costly to be a trans person. One, because, you have to, the gender reassignment, the government says it is free, but in reality, it is not free. So, someone has to pay out of their pocket for the reassignment, which can go into something like almost ₹1 million or ₹2 million. So, it's more costly than your heart surgeries, for example. And then to avoid its side effect, and the side effect of that is that you lose fertility. You have to then pay to either preserve your fertility in the form of preservation of the gametes, and then the ART and IVF and the things that follow, which again are going to be very expensive. And then if you're in India, you have to then third expense is to fight the court cases. Because the moment you say that I'm a trans person and I want to make use of ART, the court will say you are not allowed. And then you have to do, years of court cases. So it's a lot of struggle, and that's why you only get to hear a few cases of fertility from trans people or from LGBTQIA. I mean, last 3 years, for example, all the Bollywood celebrities were going for surrogacy, whether it was Shah Rukh Khan, Karan Johar, now you don't see that happening because last 3 years it is not being allowed. Commercial surrogacy is gone. It's only altruistic surrogacy, and that too with a lot of restriction. In terms of cost, and this is in general, I'm talking about for infertility, the government will have to now think about funding infertility treatment. As you all know, probably that Sikkim is one state where the state government is paying for the IVF. Because there's a demographic shift which is happening. The number of children that people are having now, especially in metros and some of the states, is less than two. Sometimes it is less than one also. And a lot of couples are now having primary infertility. And therefore, somewhere, where the government funded contraception to a great extent, now the government will have to look into funding infertility treatment. And there are certain examples of that happening even in India. One such example is the Parsi community. I'm sure you know about the Geo Parsi initiative, which was there by the government, where the government tried to increase the population of Parsis. And one way of funding that was to have more fertility. And second is the Sikkim example, where the IVF treatment are being provided through the government funds also. So somewhere along the line, this thinking will now have to start ki how IVF can be covered in insurance, including in Ayushman Bharat. We have a massive insurance scale available. Or can it be provided to people on a co-payment basis? So some kind of mechanisms of funding, because we talk about family welfare, and family welfare includes infertility management also. So I think that larger discussion will somewhere have to take place, and especially on the insurance front.
Thank you, ma'am. One more question, actually, that was there. Actually, a lot of LGBTQ plus people, they face there is something called they have to explain the doctors about various situations they face. And are there any formal course a doctor can pursue in order to understand better the conditions of LGBTQ plus people and serve them better?
Yes, so in terms of courses, there are courses which are by WPATH, World Professional Association for Transgender Healthcare. And in India, it is being done through IPATH, in which AIMS Delhi is one of the parties to it. And these courses are being conducted as part of also through Association of Transgender Health in India. But these are not specific for obstetricians or gynecologists. They are in general for people who are seeing patients. And then they have these aspects of medical, surgical, endocrine, and mental health. But right now, I would say there is no specific course for ObGyn students or practitioners in terms of giving a gender inclusive care. And that is something that could be taken up by Foxy or other organizations. But yes, there are a lot of resources available on the internet, on YouTube, by a lot of universities, including by WPATH, and that can be done. And in the paper, one place it was written that cultural competence is also better called cultural humility. I think that is something very important. Whereas doctors, we should have that humility to learn from Google, from internet, from our patients also, from their relatives also. So we should have that humility. And trust me, I have learned a lot from Instagram, from the videos of the patients and the doctors working with these patients on Instagram. So that typical stereotype, ki, oh, Google doctor and Google patient, I think that's very misleading. And a lot, especially on these underrepresented topics, because there are no textbooks available, there are no courses available. We learn from patients only, and we learn from them. So yes, there is no particular course currently available. And I think that is something that we all will have to develop in future ourselves. Meanwhile, there are a lot of YouTube related online courses which are there. And in India, in general, we have through the Indian Professional Association for Transgender Healthcare. So that can be useful. There are some more papers available on how to make your clinic trans friendly. So those can also be referred to. I can share some of these resources if I maybe on the email ID of SIMSOG. Yeah.
Yes, ma'am. Sure. Ma'am, one more thing, a follow-up question. Basically, you mentioned that cultural competence is mentioned in the paper, and also the clinics are very, very busy. And during
Mm.
that, how we can ensure that staffs are not very rude to LGBTQ plus people, and they maintain a humility toward them.
Hmm. So I also teach compassion to the healthcare professionals in my own institute. And one of the common reasons given ki we can't talk politely to people is because we don't have time, or we are dealing with busy OPDs and there's a lot of rush. And I think that's a valid reason. That of course, I mean, when you have only 5 minutes with the patient, then how can you tell everything to them, right? But then at the same time, this is often an excuse that is given for bad behavior, and it should not be an excuse. One is, I think, one important solution for this is that you, as a doctor or as a clinician, cannot do everything. We all have to work in a team. So you have to see what is there that a nurse can support you in, that a GDA can support you in, that an MBBS student who is attending with you can support you in, that an intern can support you in. Second is a lot of things can be told to the patient in the form of patient education pamphlets or materials. We also use YouTube videos with patients to tell them, for example, if they're coming for a pap smear, what they should be expecting. That can relieve a lot of anxiety when the patient is coming, or what questions you should be asking to your doctor after, you get a report of your pap smear. So a lot of these things can be done, and we'll have to evolve those models of, educating our patient and reducing our burden of speaking with the patient more. But I think when it comes to respecting, that does not need a lot of time. Just the body language of the doctor and all can, convey that they are respecting the patient a lot. And I would say it's a teamwork. Take care of your team members, involve them in providing care, use a lot of resources that are available, and it should be easy. One example is the PCPNDT Act. There's a lot of paperwork that is involved in doing it, but still we do it because the law is mandating it, right? Um, or when we are performing medical termination of pregnancy, there's a lot of paperwork that is involved, but we do not forego of that. Similarly, we have to understand that compassion is mandatory, and not because of prevention of violence, but compassion is mandatory. And once that we fix ki ye karna hi karna hai, then we'll find time and ways of doing it. So I think that's important thing to understand, that it is not optional to be respectful or compassionate with my patient.
Thank you, ma'am. Do we have any more questions? Okay. So, ma'am, one last question was there. It's a very practical question that in clinics, the paper mentions we can put up pride flags just to maintain an environment of inclusivity. But on ground, it is seen that there are various communities which are not accepting, uh, are not yet open to these kind of uh, environment.
Mhm.
How we can make our community more inclusive to all kind of people?
Of course, we can never please everyone. That can never happen. I mean, that is something that we'll have to understand. अभी किसी को खुश करोगे तो कोई तो नाराज होगा. If I want to, for example, let's say कि the Muslim patient should feel comfortable, so I put some religious symbol over there, then maybe a non-Muslim patient will get offended or something of that sort. So we follow whatever, the basic thing is people have to feel respectable. I have to see more of acts of you know like it's also mentioned in the paper that when you are putting up the posters, for example, if there are 10 posters in the clinic or in an infertility clinic and all of them are showing cis het couples, that means there's one man and one woman, can out of those 10 posters one show that there are two mothers? We are not saying ki all 10 posters have to be like that. We show ki this is also possible and this is also possible. You put a flag of India, you put a flag of pride, you don't put a flag of pride. Whatever, it doesn't, I mean, makes a difference. I personally, in my room, there is no pride flag which is there on the table. But someone who knows, ki, okay, she's Dr. Aqsa, will be comfortable with them, right? So, and one can be very disrespectful to their patient even after putting a pride flag on the table. So that is no guarantee that we are sensitive or not. So it's important because it tells someone ki, and then we can put it in writing also that we respect patients of all gender, sexual orientation, sex. No one can take offense to it. The word LGBTQIA need not be put in there. So these are the small, small steps that we'll have to do to maybe then become a more inclusive society. Because I understand completely that there will be resistance to anything that we do, and people will say, ye kyun lagaya, wo kyun lagaya, and you're catering to these type of patients. That will happen. Let's go slowly and make it inclusive for everyone. So that I think can sort a lot of issues. Because अभी हम आज प्राइड की बात कर रहे हैं. I some other forum I will speak about persons with disability and I'll say कि देखो कि आपका क्लिनिक डिसेबल्ड फ्रेंडली है या नहीं. फिर मैं आई से कि न्यूरो डाइवर्जेंट पेशेंट भी आएंगे आपके पास, तो क्या आपके पास ऑटिस्टिक महिलाओं के लिए आपका क्लिनिक फ्रेंडली है या नहीं, राइट? सो वील हैव टू अडेप्ट टू दी पीपल एंड वी विल अडेप्ट टू एवरीवन. यू कम एज यू आर एंड वील सी यू एज यू आर. It doesn't matter who you are, whether you're a person on spectrum or person who is queer or person who is radical feminist. We'll take care of everyone. Or whether you are a criminal, will take care of you also. No problem.
Thank you so much, ma'am. Do we have any question? This is the last call. Do we have any question for the session? Okay. Thank you so much, everyone. Special thanks to Dr. Aqsa Shaikh for this insights and Dr. Deepika Balani for the presentation. We conclude the session by this. Thank you, everyone, for joining.
Thank you. Thank you. I really enjoyed it. Thank you so much.
Thank you, ma'am.